Hello, and thank you to all who have tuned in today for this call. Really appreciate you taking time out on what is looking to be a beautiful day outside. So I will today talk a little bit about our agency priorities, as I do in all of these, a little bit about the legislative session that we just came out of and how a lot of those bills intersect with them. We'll spend a little bit of time today talking about the return to normal process in Medicaid and then our restarting of cost sharing. But let's first start off with our agency priorities. I think it's always good to revisit these on every one of our meetings and every one of our calls. By way of background, we've really had three major priorities that we have been focusing on this year. One in childcare, and that has really been focused around making sure that we make childcare more affordable, more accessible, and higher quality. Our mental health priorities have really centered around creating a statewide mental health system that is really able to both respond to and to prevent crisis. And then our aging reform, of course, that work has been focused predominantly on reforming our Medicaid system and our home and community-based waivers in a way that allows us to have a sustainable system that allows more Hoosiers the ability to stay at home longer. And so as we look at that, I'll talk briefly about session and how several important bills really intersect with those key agency priorities. Now, childcare has been a priority for the governor really for the last 3 years. And if we combine that along with the legislative support, we have seen the largest number of initiatives that our Office of Early Childhood and Out of School Learning has ever been engaged with. So really want to thank Courtney Penn and her entire team for the tireless work really over the last several years. In the last year, for instance, we administered over $35 million in grants. And that collectively has meant that we now have 1,800 more childcare seats available across the state, and that we have supported a number of businesses that are expanding access and affordability of childcare to tens and thousands of their hardworking employees. In addition to those, we completely reformed our payment system, going from a market-based to a cost-based system in a way that really is better able to support providers. And so what we've seen is at a time where we've heard of other states who are seeing stagnant or declining number of seats in providers in childcare, we have really seen the opposite, rather increase both in providers and the number of available seats across Indiana. But we have a lot more work to do, and we know that. And so building off of this work, this session, we continue to put childcare in the spotlight, seeing both the governor's office, the House, and the Senate all making childcare a priority. And so I'll highlight just a few of the initiatives that came out of this session. House Enrolled Act 1102, there's a lot of childcare parts, but the one that is worth mentioning here is it fits with the work we've been doing over the last several years to identify and reduce administrative burden on providers. And so we will be extending the licensing term now for centers from 2 years to 3 years, reducing that particular burden. Senate Enrolled Act 2 really was in close partnership with our agency and the governor's office, and really had a variety of initiatives that really keep childcare more accessible and affordable. One is aligned with what we just talked about in regulatory reform. It has moved up a deadline really for us to put into effect regulatory reforms that are really going to reduce administrative burden. It creates a new priority eligibility category, and really excited about this one for the employees of childcare providers. So this will make it easier for those who work in childcare facilities and have children of their own needing childcare to be able to get affordable childcare through our CCDF program. It also creates a new priority eligibility category it creates a new pilot for micro centers. This is a new area that we are going to be involved in. And so looking at this as a way to make it easier for providers to open up multiple sites. And it also puts changes in the requirements around ages for individuals to work in various supervised settings in childcare, really expanding the childcare workforce. And I think also really appropriately by lowering some of those ages, exposing folks earlier on in high school and beyond to childcare as a great profession, and really helping to kind of create a more streamlined and more robust pipeline for more employees in this. In addition, along with trying to make it easier for providers, we're also looking at opportunities to streamline background checks for childcare providers to really make the time it takes to get employees into the workplace faster. And so all of this really together adds to the ongoing work that we have already done in childcare. I am really optimistic that this is going to stay a legislative priority in 2025 and beyond. And with that, we will see more programs and more state investments. I think it's critical, as we've seen, because as we continue as a state to really focus on our economy and growing our economy, it has been really great to see across the board the recognition that central to a healthy economy in the state is accessible, affordable, high-quality childcare. So we remain committed to partnering with the legislature, the governor's office, and you, our stakeholders, on doing the ongoing work to continue to advance childcare across the state. Certainly, along with childcare, mental health has been a priority for our agency and also for the governor's office. Really going back to his very first agenda, really looking at the drug epidemic. And so not only on that work, but also expanding access to crisis services. Over the last several years, we have seen truly unprecedented amounts of investments in mental health across the state. And the good thing is, along with that, we've also seen success. In 2022, for instance, which is the last year we have the complete data from the CDC, we saw overdose deaths declining in the state by 5%. So that is obviously welcome news. Now, there's still far too many deaths, and we acknowledge that, and there's still work to do. But I think a lot of the decline that we're seeing really is attributable to the state taking such a proactive stance in things like naloxone distribution, where hundreds of thousands of doses are made available every year around the state. Making residential treatment beds more available, as we have expanded those, growing state recovery hubs, and a variety of other programs. In addition, we have seen the successful launch of Indiana 988. And as you all hopefully know by now, this is a 24-hour crisis line that really is there to address mental health crisis across the board, whether it's related to substance use disorder, mental illness, suicidality, however the individual defines that crisis. And with the launch of this, we have actually started to see some growth in the number of calls. We're now routinely seeing over 5,000 calls per month. And despite that increasing volume, we have remained in the top tier of states for our in-state answer rate, with most of our months being over 95% or greater at in-state answer rate. And we have gotten really to these points by prioritizing the work in the legislation. And this year continues to build upon our commitment to mental health reforms. Now, this particular year, really, we were looking at building on some success we have seen in our reduction of wait times for individuals who are found incompetent to stand trial. By way of reminder, if an individual or someone is arrested for a crime, but secondary to either a mental health, medical, or other condition, they can't understand or participate in their own defense, they may be, after an evaluation, found incompetent to stand trial. Now, when that happens, they're committed to the Division of Mental Health and Addiction, who is charged with providing those competency restoration services, which is a variety of services in education and treatment, really to help individuals get back to a state where they're able to participate in their own trial. And that's really important because the sooner we can get these services started for an individual, that means the sooner those individuals will often get mental health treatments, and the sooner they will then get to be able to participate in their trial. Contrary to that, the longer it takes for these services to get started may mean that individuals may be residing in jails or other locations that really are not typically conducive to improving their mental health. Now, during the pandemic, the time it might take for an individual after they were found incompetent before they could get into one of our state facilities to get competency restoration services could be as long as 4 months. And so we formed a team, and really under the leadership of Katrina Norris and Leslie Huckleberry, and of course, Jay Chowdhury and DMHA, they put together a comprehensive and really implemented a comprehensive plan to address this wait list. And what we were able to see is that decreased from 4 months to just 2 weeks in a year and a half. But to the credit of this team, they weren't content to stop there. And that really ties into one of our agency priorities this session, which was to build off the success we had in reducing the wait times after somebody was found incompetent to looking at how long it takes from the time somebody might be arrested before that competency evaluation can be found to determine that they're incompetent. Because although we've reduced it after they're found incompetent, if it takes a long time for an individual to get the evaluation and to be found incompetent, that also adds to time that they go without potentially treatment. So House Enrolled Act 1238 really helps us address this issue. One thing it does is it requires DMHA to set up competency evaluation certification and training. And so the goal there being that we're going to increase the number of providers out there that are able to do these evaluations. Another big part of that, it reduces the number of required evaluations that have to occur from 2 to 1, with an important caveat, and that is that both prosecution and defense deem that 1 is adequate. And the reason that's important is that if you have to have 2 separate evaluations, then that increases the time to find somebody incompetent. Whereas a lot of times both sides agree that 1 really would be adequate. So that will help to reduce that time as well. And for that second evaluation, when both sides or one side agrees that we need another evaluation, that now will be allowed to be done by more than just a physician and psychologist. Is it now would also allow additional evaluations to be done by a licensed APRN or PA or other physicians that are certified from DMHA. So this really, for the first time, allows us to start to really expand the provider group that can do these evaluations, that we really think over time will really make this part of the process occur much faster. Another issue with this that really was addressed in a really important part of this bill is that at times we'll have individuals who are arrested for a low-level offense, maybe think about trespassing or something like that, who are found incompetent. And because of either their medical, intellectual, developmental, or other condition, will never be able to be restored to competency. And since they're committed to DMHA, the challenge is then them residing at a state hospital for long periods of time when they can't be restored to competency, when they would be better served returning to their community. And so part of this really allows a path for dismissal for individuals who cannot be restored to competency, who have low-level offenses, and who are really not a risk of returning to their community. That's both good for them to return to their homes, community. It's also really good for the state hospitals because that then opens up a bed, which allows us to continue to serve people timely in our facilities. So that is a lot of great work that occurred this last year, but we're also preparing for the upcoming 25 session as well. And I think one thing to note as we go into that session is that as a state, we submitted an application to be a SAMHSA designated demonstration site for Certified Community Behavioral Health Clinic Pilot. That's a lot of words to say we applied and we're hopeful to be awarded that will allow us to pilot a new way of paying and providing mental health services. And we would be doing so with 8 of our community mental health clinics. And this really, for us, if awarded and moving in this direction, will really be a monumental shift in making community mental health services more accessible. So we're keeping our fingers crossed on that and doing a lot of work really to prepare for that announcement in hopefully June or July this summer. In addition, one of our priorities has been really for the last 4 years, as well as the governor's office, on reforming our aging system. And we've been working with countless stakeholders and really across the agency to design and implement reforms to the current Medicaid system that make it easier for older Hoosiers to stay in their homes and communities as they age if they choose to. Now, key to this has been creating a Medicaid system that is much easier for individuals to navigate. And the Indiana Pathways program does that. With its launch coming here this summer, in really just a few months now, the Pathways programs makes it so that Hoosiers who are 60 and older who need Medicaid services, and that's regardless of whether it's state plan or waiver, and who need Medicare services, can now potentially have one entity that manages all 3 of those. Now, that entity will be one of 3 managed care organizations, Anthem, Humana, and United. While there's a lot of attention on this program and the Age and Disabled Waiver Services, it really is only one of the ways that we are addressing the needs of this fastest growing population in our state. So with the governor's office support, we have also begun work on a multi-sector plan on aging. This is called the Age Forward Together initiative. This is being led by Leslie Huckleberry in our Division of Aging, and it will bring together public and private stakeholders such as AARP and AAAs, as well as many others, into a multi-year planning process that will really create the blueprint for the state that will allow Hoosiers to thrive in their communities. And connected to a session, one area in this legislative session that does impact the aging community and is factored into this work is Senate Enrolled Act 109. And that really, for the first time, is going to allow us to rethink the way we provide adult protective services for the state. Prior to now, we were unique as a state in that these services were provided through the prosecutor's office. But now through Senate Enrolled Act 109, we'll be exploring ways to better align what the needs are of individuals who come in through the adult protective services with the programmatic supports we provide. So really acknowledging a lot of the challenges that individuals have who intersect with the system are related to social issues and self-neglect. We'll be looking to better provide services that align with those individual needs. So there's ongoing work that we will be doing as part of that over the ensuing months. And of course, legislative session, there was a lot of focus on the Medicaid program. And certainly with House Enrolled Act 1120, we have added much more transparency to the way we collect information that we use as part of our Medicaid forecast, including Medicaid expenditures. And with that as well, we'll be doing a lot more of sharing of that information on regular cadence and on our websites. In addition, really for the first time, House Enrolled Act 1120 charges Medicaid with putting forth recommendations on what a minimum amount in terms of percentage that reimbursement should be to support the individuals that are providing a service. In this particular case, of the rate that we pay, what percentage of that really should go to the individual who provides personal care services? And so we will be working on that and bringing forward those recommendations to the legislature in January. So I'll pivot now from session really to the returning to normal in terms of our Medicaid operations. And that's because March was an important milestone, not just because it was the end of session, because also with the end of March, that ended the 12-month period that we had to return our Medicaid redetermination process back to the operations that existed prior to the pandemic. And I cannot stress enough the monumental amount of work that our teams did. Sunshine Beam and our regional DFR leadership, our Medicaid teams with Nana Spinner, Michael Gargano, Cora Steinmetz, Brian Erwood. We had so many folks, and combined with our Michelle Holtkamp and our communications team, and really taking this monumental amount of work and trying to roll this out in a way that really focused on the member who needs these services, and doing everything we could to communicate this in a way that kept folks who maintain eligibility on those services. So this was huge because we saw that, through the pandemic, Medicaid increased to over 2 million members. And so that meant that we had an over 50% increase from pre-pandemic numbers in the number of redeterminations that we would have to do. So by focusing really on those who need Medicaid, we did massive communications. And I've mentioned this before, but even before we started the return to normal process, we sent out over 700,000 postcards, nearly 50,000 texts. And that was even before we started the 12-month process. And over the last 12 months, we've sent renewal packets for over 1 million members. We did 500,000 warning letters, 300,000 texts, 160,000 outbound calls, hundreds of thousands of emails. And across that, we saw those efforts really have an impact. We saw procedural disenrollment rates continually drop over the last year, and we saw more and more individuals being renewed as they were responding to our communications, getting us the information for us to make those determinations. And so I think it's really telling that as a state, we navigated this entire 12-month unwind period process without having to pause or change our work, which a lot of states had challenges that they had to pause their redetermination process. And we also did this with transparency and continue to do so. That's why you can go to our website today and look on our dashboards on the Medicaid enrollment and renewal. So if you go to in.gov/Medicaid, if you click on how return to normal will impact members, you will see those dashboards there. And included in that is all of our monthly CMS reports. So we have that information out there for anyone who's interested. Now, with our return to normal also comes the requirement for us to resume cost sharing. As is designed in these programs and statutorily required, our HIP, CHIP, and MedWork programs have co-pays. And in addition, HIP members, some of them have a premium payment. So as we now approach resumption of these pre-pandemic programs, we will do so the same way we did with the unwind, which is really focusing on outreach and communication and on being transparent. And so on this slide, you will see important timelines for resuming our cost sharing. And notable dates that you'll see on this include notifications that are going out this month and the next to members. I think we've sent out something like 300,000 notifications already about the resumption of cost sharing. And then another one is important is that you'll see is in July is when invoices will be mailed out for the August invoices. So we'll be sending ongoing notifications as well. In addition, managed care entities will also be communicating to their members about resuming the service. And as we did with the PHE, we're asking you all as well to help by sharing resources that we have made available on our webpage with anyone you intersect with who either works with folks on Medicaid, serves Medicaid members, or who might themselves be on Medicaid. So if you go to our Indiana.gov/Medicaid site and you then click on the cost share restart, you'll get access to these materials. One thing that you'll be able to direct folks towards is information on who does this involve, what are the members that have a cost share, How do they pay that, depending on what their MCEs are, what their likely power account contributions will be in HIP based on their household size. So lots of information that is available. Also with that, we have available materials that can be shared. Included with that are sample postcards. Here is an example of one, front and back. We have flyers that are available, table tents that are available, and of course, social media examples. And so keep an eye out for this information as well. And to the extent that you can, please feel free to use these and share with individuals. Just like with the PHE, this will be another big lift for our DFR and Medicaid teams, but as we have done throughout the last 12 months, we will continue to do so thoughtfully in a way as we really get back to truly pre-pandemic operations. So you can see that while there are some things that we are wrapping up, particularly as we're in the last 9 months or so of this administration, there are other things that are just getting started. And so as an agency, we will continue to work with you, stakeholders, and others, really to move towards that vision we have, which is that all Hoosiers live in fully engaged communities and reach their emotional, mental, and physical greatest well-being. So as part of this, we'll continue to work with you and to reach out with you collectively so that we can all improve the lives of Hoosiers. So thank you all for tuning in today. I appreciate your time and all your ongoing collaboration.